Okay, so our last part of the last subsection for culture and psychiatric diagnosis. Um, so, in looking at cultural concepts of distress, importance to psychiatric diagnosis. So, the last this bit of last bit here is again these are restating of the similar themes that we've been talking about in this subsection and even um, in this broader section overall. So the incorporating social and culture contexts, that was stated in the negative there, stated in the positive, reduces the risk, I believe, and I think this is what the authors are trying to convey to us too, is that this reduces our risk of misdiagnosis, and I think it also can help reduce the risk of bias. Helps us keep in check with our bias if we're looking at the whole of the person, right? And I think we can then better see them as an individual and avoid generalizations, which is can be where one of the many places where bias can sort of generate from. Okay, so one of the things I would add about an individual processing their environment is also how media consumption may impact how they're processing the environment. This is definitely something I've seen more of in the last few years. That the amount of time people are spending on media and the choices of media that they're accessing, those two factors can really have a significant impact on how they're perceiving themselves and how they're perceiving the world around them. And it can be, in some circumstances, a source of distress and a motivator for behavior that is ultimately counterproductive to the world around them and themselves. So that's just a thought about that. That's not explicitly stated in the book. The book doesn't, the DSM doesn't really get into that media aspect, but it's something I'm seeing a lot and in clinical work, and of course we talk about in policy classes too. So anyway, that's just a share from me to you. I think the other positive in all of this is that if you're bringing in the whole of the person, you're asking them about their social circumstances, and you're asking them questions that create, hey, I'm trying to understand things in your cultural context, whether the client is very similar to you or very, very different than you. In either case, my opinion is that if a client perceives, again, no matter how similar they might see themselves to you or how different they may see themselves from you, is that if they perceive you're genuinely interested in their perspective, you're genuinely interested in seeing the world through their eyes, even if they're struggling to process with what they're observing, what's going on around them or in them, or both, that they're going to be more forthcoming, that they're going to be more comfortable and more likely to share the data that you need. Okay, and not that this is about like eliciting data. That's not the end point. But again, it's about creating an opportunity for helping and healing and growth to happen. Okay. Um, I would say that all of this stuff creates a more sad, certainly for all of you as social workers. I assume you wouldn't be here in social work school if these concepts weren't of interest to you, and that you want to pursue behavioral health clinical work and through like this lens of social work. But I think it creates the opportunity for a better experience for you as well as the client. And I think, and I've read some studies about this. I have one of them that I include in my integrated health class about how getting more of the social aspects and the cultural aspects into um, the assessment and treatment too. Um, and the client has a better or patient has a better experience and the outcomes are better. All of those things create a better experience for the provider. So even clinicians in other disciplines, I think, and there's some research data to support this, will have a better experience when they're including these things and they're connecting with their clients or patients better and they're seeing better outcomes. All right. Again, that's just the book doesn't really get into that. It's just something I'm offering to you something I've seen coming out of this, and I've experienced it myself. Um, Obviously, the part about clinical research, and we're focused on that assessment and intervention, diagnosis, intervention planning process. But all of this stuff is equally applicable to research. I think we could take a lot of these same concepts and put them into an epidemiology or research class. Certainly, one of those things in terms of recruiting subjects, I like participants better than subjects for research, and making sure, if we're thinking this way about social and cultural context, I think, and research is not my area. I'm really focused on clinical more than research, well, a lot more. But my impression is that I think we would have better results in representative samples and research that we can defend as, addressing bias and trying to filter out bias out of the research process. So again, I'm not a research expert. That's just my 2 cents about it from my vantage point. So cultural terms and explanations should be included in case formulations. And this is part of our exercise. We have a separate section in our template to sort of prompt us to pull in as much social and cultural context as we can based on the data that we get from each individual virtual case study. So we're going to do that. That's going to be part of the exercise. And of course, and this is direct from the book, that individuals with symptoms do not meet criteria for a specific mental disorder may still expect and require treatment. And as far as social work goes, they have a right to it, an inherent right to it. And that's assessed on a case-by-case basis in terms of meaning, could they benefit from our help, and what diagnosis might they best fit. Okay. So in summary, all the material represents I'll read this. All the material represents components of a culturally competent diagnosis and supports the goal of better integrating social and cultural information into clinical practice for the purpose of better health and social outcomes for a better experience for the clients and the clinician. So that's basically everything we just talked about. Creating better opportunities for good experiences, and opportunities for better outcomes. That's the whole idea. So that closes us out in terms of this is a conclusion of all the content that's not specifically related to a diagnostic section of the book, meaning specific diagnoses that we're going to go into. So I hope all of this content from the last 2 weeks is going to be, you're going to find that helpful to you as we get into the individual diagnosis sections. Okay, so thanks for listening, and I look forward to navigating with you through the diagnostic selections that we selected for us to cover in the course here.